potentially. And I know this is something that the CMO is looking at hard and thinking about the right advice for those people. I think for everyone in the public sector working, and those continuing to work in aspects of the private sector as well, clearly, the more we're going out and about, we do all carry some risk of catching this. To go back, though, to the point that was raised earlier, for most people this is a mild illness, and we just need to remember that for the vast majority this is a mild illness. So I think advice around specific measures for vulnerable groups, those most at risk, is what NHS and DHSC are producing.
Yeah, and I've also noted that there's been some talk of advice given to those who are pregnant. What would you also say to those, and I declare an interest in the sense that my daughter is just 12 weeks old, but to mothers and carers for very, very young children, babies?
I don't want to dodge the question so much, saying that's really a question for the Chief Medical Officer.
Okay.
I mean, I know I'm a doctor, but
No,
I haven't practiced for a long time, and it's not, I don't want to be giving advice that's really the thing that the CMO and the NHS should be giving.
Okay, that's fair enough. Is the government engaging with those scientists that disagree with your plans?
Oh, completely. I mean, absolutely. If you think SAGE and the way SAGE works is a cosy consensus of agreeing scientists, you would be very mistaken. It is a lively, robust discussion with multiple inputs, and we don't try to try and get everybody saying exactly the same thing. The idea is to look at the evidence, come up with the answers as best we can. There are subgroups that work and feed into SAGE. And the membership of SAGE, I should say, changes depending on what we're discussing. So it's not as though it's the same group of people that always discuss all the topics. There are members that come for specific items.
And you made it clear that your role was to advise. How much do you believe that the current strategy that's being driven by scientific evidence, and how much by behavioural science, and how much perhaps by economic interest?
Oh, I think the advice that we've given from SAGE, which is based on modelling, virology, clinical, behavioural science, actually even other areas of science as well, that goes to the government, has been really carefully listened to, and has not been in any way, from our perspective, overlain with economic considerations as a reason to change the advice. Okay. So it's very straight advice. We're interested in two things. We're interested in saving lives and protecting the most vulnerable, and that's been the driving force that will continue in all of our outputs.
And just finally, other than what we've seen in terms of the regular conferences, I think daily conferences we're going to see from now on, what strategies are there in place to ensure effective information is given to the public and other organisations on the essentials of the plan? Yeah,
again, that's not really a science question in the sense that I can't, I'm not in charge of the communications of it, but
no, sure.
I do think it's critically important. I mean, it's very obvious that this is complicated, it's frightening. People don't know what to do sometimes, and therefore the clarity and the ability to keep repeating the same thing in a way that people can understand, I think, is crucially important. And all of the behavioural science would suggest that we've got to get the transparency right, we've got to get the communication right, we've got to trust that actually people want to know things, they want to know about this, and they want to be able to be empowered to make their own decisions on this. And I think those are some of the key things in terms of how we communicate this.
Okay.
Thank you. Laura.
Thank you. There were some very serious measures which were imposed yesterday. You mentioned earlier that what happens when you release them is the big unknown. And you also said that we've got to look at what is the consequence of backing off when we think about taking them off. Can you just talk us through what the process is for these measures being lifted and when you think that might happen?
Well, we're just at the start of implementing them, so I think we're nowhere near talking about releasing them. They're about making sure we do them properly. And as I said yesterday, and I've said again here, there may be other things that needed to be added, and we've talked about one of them here. There may be others. When we get to the stage where we've got the outbreak down to a level where we know we can keep it below the NHS capacity, which is the aim. And when we're happy that that can really be maintained properly, that's the time to start talking about how you might release it. And there are various ways that you could think about that in terms of backing off a bit, seeing what happens, putting things back. And that, I think, is the sort of approach that might be necessary in due course, but we're not there.
Do you have a figure in terms of that NHS capacity that you're working to?
Well, the NHS capacity will come from the NHS, so they
Yeah.
will provide the figures as to what their capacity is, and then the models can obviously, and the data streams can flow into that to say, well, where are we against that capacity?
Fine, so there's not a number now that you have that you know will be the case, that is the capacity that when you think you can manage that number, you will lift the restrictions.
Well, so there are two bits to this. That there's the infection itself and how common that is and how much that's going to increase or decrease.
Yep.
And then there's the capacity of the NHS, which they're working on incredibly hard to try and increase. And so that number's moving, both numbers are moving, and obviously both of those numbers are the ones you need to keep an eye on as you think about when you might be at a stage when you can think about backing off.
There are some people that are suggesting that these measures may last 18 months. Is that something that you think might be credible or not?
18?
18 months, yes.
I don't know how long these measures are going to be needed for. I think the modelling so far suggests that it's certainly not a couple of weeks. And one of the things that I think, if you look at some of the approaches that have been taken, the assumption that you might just close things for 2 weeks and start up again is not correct. It's going to be months. I don't know how many months. It's going to have to be data driven. In other words, as you see things changing, you might need to do more, you might need to do less. And by the way, that might happen quickly, just as it did over the course of the last week.
Yeah.
That isn't because there's a sudden change of strategy, it's that you're responding to the information you've got in order to change, and that's what we need to be prepared to do. And I think we're going to have to be equally nimble as we think about backing off again. And we're going to have to try it. And one thing is, for sure, we haven't got immunity to this virus, and therefore, as we back off, it may come back again, and we're going to have to manage that very carefully. And we're going to have to hope that we can get through quickly with some of the other interventions as well to try and get on top of this. So vaccines and the other approaches that are being taken, which I have to say, I think there's been really remarkable efforts and progress in some of those, but we're still a long way off.
And in your conversations internationally about countries that are further ahead than us, do you have an idea of what their plans or what their approach is going to be to actually lifting the measures? For example, potentially China.
Yeah, not really is the answer. I think everyone's asking the same question, and you look at some of the scientific papers coming out from China and elsewhere, people are looking at what could happen, but we don't know yet. And I think all of the evidence from previous epidemics, and this type of infection would suggest that you can't avoid this bubbling back up again when you lift off. So that's what we're going to have to be aware of, and that's what we're going to have to try and manage.
And when you say bubbling back up again, do you mean a spike, or this being something like we would understand as seasonal flu?
Well, seasonal flu is, in a sense, a spike every year, and that may be what this ultimately becomes, something like that, and that may be what we need to plan for. So I mean, there are two ways that you can think about it. So I think if you withdrew all of the measures immediately, you'd probably have a lag phase and then a peak. Mm-hmm. If you withdrew some of them, you could begin to sort of see, is it just sort of creeping up, and you're beginning to see an effect, and you might then reimpose them. So I think that's why I refer to sort of an agility in managing this is going to be quite important, I think.
Thank you.
I've just got a couple of questions from our colleague James Murray, who's not able to be here. But I wonder if I could just follow up on one of Laura's questions there, because I think the thing that's puzzling people who look at other countries, China officially announced they think they're past the peak. South Korean foreign minister was on TV at the weekend saying that she thinks that South Korea has passed the peak, and they seem to think they passed the peak with less than 1% of the population being infected. And they're very realistic. There could be second waves, third waves, but they don't seem to be expecting it as much as you do. And I was just very struck by the phrase you said just then. You said if you look at all the evidence, you can't avoid concluding that it's likely to come back. And I just wondered if you could explain to non-scientists, because I think the Chinese view, the Korean view, seems to be that it could be something like SARS, for example, which just burns itself out when the reproduction rate gets below 1. Why is it that you're unfortunately so certain that it will come back?
So I don't want to be up merchant of doom on this, but I think the transmissibility of this virus is very, very unlike SARS. I mean, SARS was not transmissible in the same way as this, and it had a very high mortality rate. This has got actually a rather lower mortality rate. It's got a very high degree of mild infection, and just today there was a paper that I was reading from China suggesting that something like 86% of the infections in Wuhan were not ever detected before at the time. So there's a very high degree of transmissibility. All of those characteristics, from the evidence from everyone we've heard from, suggests that when you lift, you're going to get something coming up again. Now, I can't tell you how big that's going to be, and we may be lucky, and maybe it doesn't, but everything suggests that that is what you would think in an outbreak like this, with a virus like this, with the sorts of properties, would be what you would expect to see.
Thanks. And then I'll come to you in a sec, but I just got a couple of questions from...
And by the way, I hope they're right and it doesn't. I mean, that would be a perfect outcome, and like all scientists, I'm very happy if I'm wrong on that and it doesn't come back.
So these are from James Murray. His first question is, more than other countries, the approach in this country continues to segment the population with different levels of isolation. Could you explain very specifically why you've chosen this route rather than more blanket approaches with reference to scientific evidence, behavioural science, economic interest, and so on?
Well, we've said everything's the same for case isolation, everything's the same for household quarantine, asking people to stay together in the whole household. We've given the same group of social distancing measures for everybody and said everybody should take those seriously. They are particularly important to be very stringent about them if you're over the age of 70 or have another illness. And then we've taken one group of much more vulnerable people with serious illnesses that can predispose you to viral infections and to other things where there will be specific advice. And I'd be surprised if people like that weren't getting specific advice in other countries if you're particularly susceptible. So I think we've gone for pretty similar, actually, advice across most of the population.
Okay. And just to be clear, because there was a bit of debate about this yesterday, for over 70s who don't get contacted by the NHS as being someone with a long-term condition that makes them especially vulnerable, could you just explain what sort of changes in their lifestyle you're hoping for? I think perhaps the easiest way to do this is to say, what are the kind of things they might do now that you're asking them not to do going forward? These are the healthy over 70s.
Avoid crowded spaces, avoid gatherings. Don't go to the club that you normally go to where everyone's sitting around together. Reduce travel. Try to avoid unnecessary travel. Don't go out to do your usual things in terms of going to the shops and things unless you absolutely have to. So if somebody can deliver it for you, so much the better. And so there are several things they shouldn't do that they're doing now. What Chris Whitty has said, and I think it is an important point, is you could go for a walk around the garden, or you could go for a walk avoiding close contact with people, so that we're not asking everybody to be completely separated. But there is quite a big change that's being asked for, and the specific guidance is on the DHSC website.
But just very specifically, what about going to Sunday lunch with their family and their grandchildren? Yes or no? shouldn't.
No.
Okay. Yes, I've just got one more from James Murray, and then I'll come to... Oh, sorry, on that point. Yes, please do.
Just on that, so exercise is going to be key. So are you saying, when you mentioned about walking in parks and so on, is that the sort of thing where if someone wants to go and play golf, or, you know, the sporting exercise that they can do en masse, but where they're not close together, they could still do?
I think the advice is to try to avoid close contact, to try and reduce social contact. I think realistically, a walk is okay if you're keeping a distance, but it's not if you're going to be in close contact with people.
So realistically, it's possible that over the coming months, healthy people over 70 could go out to parks as long as they're keeping away from each other, effectively. So they could do group exercise, but be 2 or 3
Well, I don't think group exercise, no.
No, okay.
So I think, again, we're straying into, into areas that are very much sort of NHS advice and DHSC and the CMO advice. But I mean, I think, you know, this could go on quite a long time. I think it's quite important that we get it right. And the danger is in crowded places, gatherings where you've got a few people in a enclosed environment. Those are the sorts of things that we're saying don't do. Don't go out to the shops if you don't have to. Really make sure you do it only when it's absolutely essential. There's no other alternative. And I'm afraid it is avoiding those sorts of social interactions which are such a crucial part of everybody's life. I'm afraid we're asking us all not to do that.
Sure. Thank you.
And then a final question from James Murray. This is slightly touching on what you said before, but I just want to ask it because he's asked me to ask it. Given that the advice is slightly different for the under 70s and the over 70s, does herd immunity and the concept of herd immunity play any role in the thinking with respect to that slightly different advice?
Oh no, I mean, in fact the advice is the same, it's just saying do it more stringently for the over 70s. And the whole point about the over 70s and the vulnerable groups, most of the measures we're talking about are about trying to protect everybody. They're about trying to prevent the spread of the virus in a way that puts people at risk. For the elderly and vulnerable, it's about protecting yourself. So it's a rather different set of messages. I mean, clearly it's also part of the first message because they're not spreading it either, but it's very much about protecting themselves.
Thank you. Luke?
A couple more questions about evidence, if that's okay, particularly around medications. So a week ago, common blood pressure medications, things like lisinopril, ramipril, candesartan, a lot of people are on them. There was some concern that there could be a problem there. Yesterday, France announced that there could be a problem with ibuprofen, and the BMJ, you probably won't have time to see it today, have produced an article today saying avoid it. I wonder if you could comment on the evidence around both of those and whether you think that's advice. I appreciate we're straying to medical advice.
Yeah, no, it's fine. But I can talk about that from a sort of scientific perspective.
Please.
And I've spent quite a lot of my life trying to make drugs and making drugs, so I do know about that. But I think there's theoretical reasons around ACE inhibitors which are quite interesting, but I don't see strong, compelling data yet to know what the answer is to whether that's real or not, and that's being looked at. And the ibuprofen example, again, it may or may not be right, I don't know, but the sensible thing to do, I think, would be to say, well, don't take it at the moment, take something else, paracetamol or something.
Yeah, thank you. And one final question. What surprised you the most about the situation we're in?
Well, I don't think any of us have seen anything like this. I mean, this is a first in not just a generation, but potentially the first for 100 years. And so none of us have seen this. It's not like an outbreak of something like Ebola, where it's a very different type of disease with a very different type of death rate and a very different set of criteria around it, circumstances around it. This is a daily changing, unique situation where we're learning as we go along. We're going to have to invest heavily in science. We're going to have to research hard to find out why some people are getting ill, the real illness, why some people have a particular cytokine storm, why people get better quickly in some cases, what the vaccines are, what the tests are, what the treatments are. I mean, this is a really big, intensive research effort. And so what surprises me most, it's that, you know, as always in medicine, you find out there's a lot you don't know.
Thank you. Yes, Dean.
Sorry, I just wanted to come back on the data question. We talked about modelling and so on earlier. Just occurred to me from some of the comments you made around the use of data for public information, but also the collection of data. Testing is one thing, but also making sure we're doing the right research relies on the right data being collected. I just wondered whether any conversations have happened with places like Facebook and Google and so on to enable people to track their own journey when they've got it, as it were, in terms of the illness, and also whether you're looking at data from, say, hospitals or local areas where they can say, look, we're nearly full, so that people can see the capacity that's going on, so that it's a shared data and there's a responsibility to share that data.
So three things on that. First is that the research community, I think, has stepped up really quickly to some of this, so that we've had meetings which I've called every week or so with UKRI and the Research Fund as Wellcome Trust and so on, to try and get money out of the door quickly to get this going, and that's worked really well, and those organisations have worked brilliantly there, I think. I think the tech companies are all over this for the reasons you said, and they've been talking to government and to other governments about how we can do this. And yes, absolutely, the data flows of what's happening locally are going to be critically important to understand where NHS capacity is filling up, where there's an outbreak that's got a bit more, where there's one that's got a bit less. And I said yesterday, you know, London's ahead of the rest of the country in terms of where it is on this outbreak at the moment. Others will catch up, and we'll see it in different times at different places. We need to be able to get the right data flows from the NHS, who are working incredibly hard on this, and Public Health England, who've done an amazing job on their activities so far, to make sure we get that right to be able to monitor this properly.
Thank you.
Any other questions? On which note, thank you very much for sparing the time, and thank you for your valiant efforts. Much appreciated.
Thank you.
Thank you very much indeed for coming. We completely understand how busy everyone is. And I think the first thing that the committee want to do, actually not just on behalf of us and Parliament, but on behalf of the whole British people, is to thank you, and through you to thank the whole NHS for the absolutely extraordinary efforts they're making. I mean, it's a bit of a cliche to go on thanking the NHS, but I think when people see what's happening in Italy on their TV screens, they know what the NHS is preparing for at the moment, and we just feel incredibly proud to have such dedicated staff on the front line. So if you could pass that on, we would be extremely grateful.
Thank you.
I'm going to ask a few questions to start with, and then I'll hand over to colleagues. And I thought I might start, if it was questions about capacity, would that be Keith or Amanda, would you think?
Any of us.
Let me start, Keith, with you, if that's all right. And and I just wondered, what is the current number of general adult acute beds that we have?
Do you want, shall I maybe start on
Yeah,
this,
sure.
Chair, and then we can divvy up other things. So, as of today, we have 98,000 general and acute hospital beds open across the English National Health Service.
And the current occupancy?
The current occupancy actually has been falling, and as we speak today, is at under 90%.
Right. And of those, how many critical care or intensive care beds?
So we have 3,700 critical care beds for adults in play at the moment. And obviously, as part of our readiness for the likely influx of more coronavirus patients, we are going to be taking concerted action across the whole of the NHS to free up to a third of the general and acute beds. We want to enable perhaps 30,000 of those 100,000 general and acute beds to be available for coronavirus patients. And today I am asking the NHS to do three things to get us into that position to be able to receive those extra patients. First of all, we are suspending elective non-urgent surgery with an assumption that that will be suspended everywhere from 15th of April at the latest for at least 3 months, but with discretion for hospitals to take action earlier if they need it, either because of the pressure of patients being admitted or in order to adapt their facilities or train their staff. Secondly, we are working intensively with community health services and social care, using some of the flexibilities that the emergency legislation before Parliament will mean to unblock some of those discharge processes, as well as some of the extra funding that the Chancellor announced in the budget. And thirdly, we are working with the community hospitals, the intermediate care providers and the independent hospitals to bring that capacity online as well for coronavirus patients.
Thank you. Just cutting to the chase, the modelling that was published this morning by Professor Ferguson at Imperial, which I think the government is working on, basically has an assumption that 4% of COVID-19 patients will need a hospital bed, and of those 30% will need a critical care bed. If you take those assumptions and then you combine it with the measures that were announced yesterday, which are expected to dramatically slow the growth of the virus, are you now confident, combined with the other measures that you've already been working very hard at, that we will have enough intensive care beds for people who need them?
Well, this is obviously an unprecedented global health threat. Unmitigated, there is no health service in the world that would be able to cope if this virus let rip. And therefore, it is crucially important that the measures that were set out by Public Health England and by the government yesterday take effect in order to reduce the infection rate such that the peak pressure on the NHS is moderated. In the meantime, what the NHS is doing, of course, is pulling out all the stops to make sure we've got as many staff and beds and other facilities available, including critical care, for that peak in demand.
So I'm not trying to ask you to have a crystal ball, but on the basis of the modelling and what it would be reasonable to think would happen as a result of yesterday's measures and also the preparations that are being made, do we have some degree of confidence that as things stand at the moment we will have enough intensive care beds?
Well, those measures will certainly make a big difference and in our view were absolutely necessary. But frankly, we're going to have to keep this under review. And if it turns out that further measures are required in order to reduce the number of people who get this virus, then that will be something that policymakers and government will have to consider. In the meantime, what the NHS is doing is making sure that not just overall hospital beds, but particularly intensive care beds, operating theatres, recovery bays being repurposed, mechanical ventilation, about which there's been a lot of discussion, other facilities across the hospital sector, that they are as expanded to the greatest possible extent as they can be, so that the NHS can do all we possibly can.
And actually, just with respect to the, I think the second of the three things that you just announced, I had a message from a hospital in Surrey about a big problem that they were having in terms of discharging palliative care patients to care homes and hospices, because the care homes and hospices didn't want to take patients unless they knew that they didn't have COVID-19. And is this a problem that we have a plan for, a solution for? Will what you've announced today help deal with that issue?
We are testing patients who are emergency admissions to hospital with respiratory or question mark COVID type symptoms. So we have that those diagnoses now available to us. And obviously, as we look to discharge patients to the extra community health services, potentially palliative care services, social care services, we will have to tackle that. But I don't know, Steve, whether that's something that has crossed your radar particularly.
No, but I think Simon's absolutely right. We are testing those individuals in hospitals who have a wide range of symptoms that might be compatible with COVID-19. So our knowledge of patients who are positive and who have recovered will increase. So that information should be available.
I think the doctor who wrote in to tell me about that really wanted to know, do we have a plan to stop hospitals being unable to discharge patients in that situation? Because I think that is which is effectively a community plan. And I just wondered whether you...
So I think the answer to that is yes, but not if the implication is that we're going to be testing every single patient in hospital regardless of the symptoms that they're displaying. That is not what is currently proposed by Public Health England. But in terms of the additional financial flexibilities that have been set for out in the budget, hospitals will now be able to, with their local authority partners, go and fund additional discharge support, and the emergency legislation that is before Parliament proposes to take out all of the delays associated with eligibility checking and needs assessments, so that those transfers can take place very, very quickly. And we think on the back of that chair that potentially up to 15,000 of our 100,000 hospital beds could therefore be freed up for coronavirus admissions.
Thank you. Can I move on to ventilators?
Yep.
Now, obviously, lots of people with COVID-19 get breathing difficulties and need what's called a mechanical ventilator to effectively do their breathing for them, and that can absolutely be a matter of life and death. So what is the total number of mechanical ventilators that the NHS has access to in England?
As of today, we have 6,699 adult mechanical ventilators operational in the NHS, together with 750 paediatric mechanical ventilators, which can be repurposed, an estimated 691 in the private sector and 35 in the Ministry of Defence. So in the round, all told, we have 8,175. For some weeks now, we've been out preparing and procuring mechanical ventilators and can see a line of sight over the next several weeks to another 3,799, bringing the total to just under 12,000. And then in addition to that, you may have seen that the Prime Minister hosted a call with the manufacturing sector to seek to bring new supply into the country for mechanical ventilation, and we have set an open-ended goal for what that would be.
So just so we understand what you're up against, if we are not successful in suppressing the virus and we ended up in our reasonable worst case scenario, what does the modelling show you would actually need in that situation in terms of the number of mechanical ventilators?
Well, when you talk about the reasonable worst case scenario, if what you're talking about is an 81% infection rate across the population with none of the population mitigations in place that have already been announced, then there is no country in Europe that would be able to have a health service that could deal with all of that need, which is why it's so important that we don't get to 81% infection, and it's so important that these additional measures are enacted and succeed.
So if you take into account those additional measures, does the modelling show that when we get up to 12,000 mechanical ventilators, we should have enough?
That will partly depend on the clinical protocols that are being used for the patients that are requiring care, and Steve and Keith may want to comment on that. It will also partly depend, frankly, on the extent to which we, as the people of this country, respond to the asks that have been made of us. And it's very important that collectively we do, because that is what will keep the infection rate down.
But at the moment, I'm just really trying to get a sense. I understand that you can't predict these things, but I'm just trying to get a sense whether this is an issue that is potentially solvable. We could potentially have enough mechanical ventilators if yesterday's measures. You must have done some pretty detailed modelling of what yesterday's measures were.
Nothing is certain, particularly in an epidemic with a new virus where we are understanding the science better and better every day. But absolutely, our aim, working with the modellers that are working with SAGE and the various processes, is to ensure that we match our expanded capacity with the interventions that the government have announced, so that we have the best possible chance of having the capacity that will manage the number of patients who are infected with COVID-19, including mechanical ventilation. But as Simon has said, those measures will only work if the public act on them and the public stick to the various measures that the government have proposed. So this is important that we all do our bit in society, because the more we do our bit in society, the less demand there will be placed upon ventilators.
Yes, I mean, look, I understand you don't want to commit, but you're using phrases like, that will give us the best chance of having enough mechanical ventilators. I'm just really asking a very straightforward question. Does the modelling show what we expect to happen as a result of yesterday's announcement and the suppression of the disease, and what we expect to happen in terms of the additional new mechanical ventilators, perhaps getting up to 12,000? Does the modelling show that in that situation, if all goes according to plan, we could have enough?
It depends. I mean, I think we'll be in a better position to give you, based on what the group from Imperial and Sir Patrick Vallance, who's been speaking to you, what they are telling us, when we see the sort of impact that in practice over the next week, fortnight, 3 weeks, those measures are having. As we see the change, hopefully, in the new infection rate, the hospital admission rate, that will then give us more confidence as to what the landing zone here is going to be. But as we sit here today, less than 24 hours after those measures were announced, I think we all accept that there is a degree of uncertainty around how this will play out over the next month, 2 months, 3 months and beyond.
Okay. Then just a final area of questioning from me. I want to talk about protective equipment for staff. Obviously, it's a massive priority to keep staff safe, and indeed we owe them no less, and of course everyone would agree on that. So if you look at the key elements of protective equipment like gowns, face masks, goggles, gloves, aprons, hazmat suits, do we have any shortages at the moment?
Okay, I think Amanda's going to...
Yes, thank you. So you're quite right. From a staff point of view, we know this is hugely important, and it is something people are rightly anxious about, because they want to keep themselves safe, they want to keep their family safe. So it's got, as you would expect, a very high degree of focus from us. I think on a kind of reassuring point, we have been assured that there is sufficient supply available nationally. So we've had the benefit, of course, of being able to release our influenza stockpile and also from the EU exit stockpile. So nationally, we are currently assured by colleagues that we do have the adequate supply we need. However, We are aware that there have been some local distribution problems, so we haven't necessarily got the kit in the right place. So what we've done today is set up a dedicated helpline so that if people have got local issues that they need immediate response to, they've got somewhere to go, and we can then make sure that the distribution that the stock is being moved from where it is to where it needs to be. So this is something that's got kind of obviously a very high level of continual focus, but I think as we stand today, we have got the national supply that we require.
So I just want to ask this, and I might ask you just, Simon, just to respond to this, because I think staff will want to hear this. On the basis of what Amanda said, you are confident you will have enough protective equipment to keep staff safe, and if there are gaps at the moment, they're localised, but you will have enough to keep staff safe in the months ahead.
Well, I would just underline and endorse what Amanda has said, which is that as we sit here today, nationally, the Department of Health and Social Care procurement team have sufficient for the PPE that we're going to need over the coming weeks. But there is a distributional issue around the country, and we are going to need more of it. So let's just be clear, this is a challenge facing every country. A lot of the Chinese supply for some of the actually more basic items has been disrupted. So we are going to need to ramp up production for gowns in particular, some of the face masks, and that, given that this is not a flash in the pan, as we know, this is not something that is just going to be resolved in a fortnight or a month. This is going to, the coronavirus pandemic is going to be with us for months to come. We are going to have to ramp up domestic production on those items as well. So it's a combination of, have we got aggregate supply now? We are being advised yes. Do we need to improve the distribution to every part of the service? We think so, hence the approach that Amanda has set out. And will we need more of this stock over the coming months? Yes, we will.
Could I just read you a couple of comments that have been sent in from people on the front line, because there is such a lot of concern about this. This is from an A&E doctor who in London writing yesterday. So this doctor said, it's absolute carnage in A&E, utter chaos. We don't have any proper PPE. We're being given paper masks, not the gowns, not the FFP3 masks we need, and not everyone even gets those. Literally, the doctors seeing the sickest patients, the ones with suspected heart attacks, PE, sepsis, and all they have to protect themselves is a bit of paper across their mouth. I'm in shock. I feel like we're being thrown to the wolves here. Some of us are going to die. So how long is it going to take to sort out these localised problems?
So, I mean, first of all, clearly our staff are critical and they are doing an enormously important job, and we need to respect what they're saying. In terms of the PPE, as Amanda has said, establishment of a hotline to deal with the immediate issues of distribution so that hospitals where there are problems can contact us directly or contact the hotline directly to ensure that we get immediate supplies out to them. The PPE has changed in the guidance from Public Health England in recent days, so I think there is some education to go on as well about what is appropriate, depending on when the case is a confirmed case or a suspect case, and that is now an important part of what we have to do, is to educate our NHS staff as well, so that they do feel assured that what they've got is correct. We are in a unique position in the UK in that for two reasons. One is we have always held a pandemic influenza stockpile, and that is what the department is now drawing on and pulling that down and into that distribution chain, which is now happening. And that's something that's an enormous replenishing stockpile that we've had long term. As you know, many countries do not have that. We also, a silver lining, we inherited the EU exit stockpile, which again we managed to retain before a lot of that was taken down. So there is a significant amount there, but we do have to listen to the staff and we do have to respond and assure them that the personal protection equipment will get to them.
So the one thing that would reassure them most right now is if you gave me a date by when these localised distribution problems will be sorted out. I mean, can you commit that, for example, within the next week, all these localised distribution problems will be sorted out and the staff will have the protective equipment they need?
So we've had discussions this morning and we've been assured by the department that those stocks are there and a distribution model is going into place.
So a week?
So I was...
I think would say, so, I mean, they are being sorted out right now, but what we have also got in place today is an intention to do a kind of regional distribution so that then regions can make sure that they've got some control of additional stock that they can distribute locally. So in addition to sorting out through this dedicated line those individual issues that come up, we are putting some additional stock into the system so that regions can distribute it today so that they've got a bit more flexibility than they had yesterday.
But can that A&E doctor be confident that this time next week the problem will be sorted?
Well, I think what we're saying is we're not waiting a week.
So
we're
he
on
can
to
be.
this
Okay,
now.
if he can be, that's great.
And
That's what we want
that's
to
the intention.
know. So I just got one more, which he makes. This is a different doctor who makes a slightly different point. This is another A&E doctor from Luton and Dunstable. I'm treating patients who are perhaps presenting for a broken ankle and they suddenly start coughing all over you. You're breathing in an aerosol spray of droplets and we're not even wearing a mask, just scrubs and a plastic apron. So should the NHS, Sir Simon, nationally have a policy that all staff should be wearing PPE equipment in hospitals where there is a reasonable chance they're going to come in contact with a COVID-19 patient?
Well, I'll defer to Steve Powers, our National Medical Director, on that. We're guided by the advice that the infection control specialists at Public Health England issue, and that's the basis on which the PPE has been provided. But I think we all believe that actually staff do have a right to expect the sort of protection that would give them confidence. And so part of the question, the dialogue with PHE, is what is reasonable in A&E departments and other parts of the hospital. But Steve, I don't know.
Yeah, so I would absolutely agree with Simon. So clearly PHE are the experts in this area and issue the guidance. And as Keith has already said, that guidance has evolved over the last few weeks as we have learnt more about this virus. But equally, I think from our staff's point of view, providing them with the confidence that they are safe, as Amanda said, in all circumstances is important too. And so there is a continuous dialogue with colleagues at PHE as to setting the right approach, and I am sure that that will continue to evolve.
Just to underline the sort of national availability point, we have got right now, I'm advised, more than 28 million of the most intense face masks available, with many more in production. So those face masks are here in the country.
Thank you. And just a last question on PPE. Pulse magazine, this is for GPs. Pulse magazine had a story about GP surgeries in 20 areas being sent batches of masks which said best before 2016, and then a sticker had been put over those which said best before 2021. And a lot of GPs, and indeed the BMA, have written to us, are worried about the quality of protective gear that's being sent to them. Is there anything you can say to reassure them on that?
Definitely. Keith?
So those, we're fully aware of those. They came from one of the stocks that I talked about. They did go through a quality assurance check for health safety, and the reason they were rebadged is because that's what was appropriate. They were tested to ensure that they are of current standard.
Thank you. And then one last question for me, and then I'll hand over to my colleagues. And this is just really prompted by the absolutely heartbreaking scenes that people have been seeing in northern Italy. And the thing that perhaps the most awful stories you read are when doctors are having to choose which patient gets an intensive care bed and effectively play God because the patient that doesn't get that bed is going to die. And there's a lot of people who have been writing in saying that they don't have guidance as to how to make those appallingly difficult decisions. Is there a plan to send out guidance, particularly to intensivists, but to all doctors, so that in that nightmare situation where you have to make those choices, doctors have actually got some guidance that they can use?
So the first thing I'd say is that reason that we are expanding capacity, and the reason that we have been working with government closely on the policies that they have introduced, and discussing policies which they may introduce, which they have laid out, is to ensure that we do everything that we possibly can not to get into that circumstance. because doctors make clinical decisions with patients, with relatives every day. And what we want to be able to do is to support doctors to make those continued decisions on the basis that they are currently making them. And because we are ahead of Italy in terms of the curve of the epidemic, as I'm sure you will have discussed with Sir Patrick, that gives us the opportunity to do that planning ahead. But of course, nothing is certain in medicine, and doctors do, and clinical staff have to make a difficult decision. And of course, if that becomes the case, then we will support them locally and nationally in that sort of decision making. But I must emphasise that if everybody in the population follows the guidance that's been given, and we work on the capacity in the way that we have described, our aim is to ensure that medical practice does not have to change.
I understand that, and I think we'd all agree with that, but I just want to very specifically ask you, are you going to be sending out guidance to intensive care doctors that tells them how they should make such impossible decisions if they end up having to make them? Is that guidance going out, and if so, by when? Because that is on people's minds.
So I would say that we would be working with our relevant colleagues in intensive care, but not just in intensive care.
So you may not be sending out that guidance?
Well, I think we have to work out the best way of doing that, but I absolutely hear the concern, and it is something that we will be working with our professional colleagues in intensive care and other specialties to address.
Okay, you can't give any more comfort than that, because these are, this is happening today in Lombardy.
Yes,
people are worried it's going to happen here, and they just want a very simple set of instructions, guidance, that's all. And I think that you're basically saying we'll listen to you, and we understand this is difficult.
No, I'm not saying we'll listen. I'm saying that we want to work collectively and collaboratively with our colleagues, rather than just send out guidance. This is something that we need to do.
Okay, but you will come up with some guidance. It might not be you that have written it, but you'll come up with some guidance, talking to the Royal Colleges and whoever. Is that what you're saying?
It's an if, and as I absolutely emphasise, that is a point that we do not wish to get to. But of course, we will work collectively on guidance where it is required.
So there would be guidance before such situations arose?
If, and it's a huge if, yes, we will work on that guidance.
Thank you. Luke.
Thank you for all coming in today. And just before I came in the house, I'm a GP by background, so my questions are set is just about some of the practicalities that you might see. And if I could start with secondary care and just work my way out of hospital, if that's okay. You mentioned 8,000 ventilators. How many of them are in use at the moment?
Well, a number of them are in use for some of the procedures that we're going to defer. So part of the reason for calling a halt to non-urgent operating is that we not only will free up ventilators, but also critically a number of the operating theatres and recovery rooms, which can then be repurposed for extensions to critical care.
So you don't know if it's 5,000 are in use at the moment, because once a patient's got a ventilator, that's it, they've got a ventilator. Do you know the number in play at the moment actually being used?
Well, a number of these are going to be brought back online,
okay,
rather than being in use right now. And we've also got to work. I mean, I think you know this, but it's worth just saying, it's maybe worth Steve saying, that mechanical ventilation is not just a question of a bit of kit. I mean, it's actually a very complex and sophisticated procedure that involves a sedated, paralysed person, perhaps for 10 days, carefully being monitored. So it is about trained staff as much as it is about equipment.
You beat me to my next question.
So I think Simon gave you the number of ITU beds.
Yeah.
And of course, not everybody in an ITU bed is mechanically ventilated, and that will be changing literally from hour to hour across the NHS. So it's an answer that changes on clinical needs every minute. But a proportion of patients on those ITU beds absolutely will be on mechanical ventilators. As Simon's also said, there are mechanical ventilators used in operations, in operating theatres, and again, that number varies from day to day. So I think the key number is the number that he gave you earlier, which is the number of ventilators that are available, because our capacity planning assumes that they will all be used.
So on that, can I come back on that? Because with that, you rightly point out, how many staff do you have to use it? I couldn't use a ventilator. I could probably be trained, but it would take a while to get used to it. The other thing that goes with it is arterial blood gas machines.
Yep.
They're critical for working out what settings you need. Have we got enough of them aligned with the ventilators? So the people to use it and the machines to make the judgment and adjustments.
Well, we've been obviously talking with the Intensive Care Society, the Royal College of Anaesthetists, and many of the other medical disciplines. As we have a slowdown in non-urgent surgery, a number of anaesthetists will, with their intensivist colleagues, be available for this type of work. But, I mean, I have sat next to me a professor of medicine and a trauma surgeon, so why don't I hand over to Steve and Keith?
So again, Simon is absolutely right that there are staff that use ventilators, but not in a ITU capacity. They will clearly need some further education, some retraining if it's a skill that they had in the intensive care setting they haven't had before, and we are working, as I think you've heard, on ensuring that education is in place, and I know many hospitals are doing that already. On your other point about other bits of kit, and it's not just kit, it's drugs, etc., that are required for patients who are ventilated, then we are also looking at supply chains and ensuring that we have the supplies in place for everything else that is required around ventilation. And the final point I'd make is that there are forms of ventilation that don't require mechanical ventilation connected to a machine, so non-invasive ventilation with a tight-fitting mask. Now we think actually, from the experience that we have heard about in other countries, that the clinical course of this disease is such that we want to place an emphasis on mechanical ventilation. And that is exactly why, as you've heard, our efforts are aimed at increasing the supply and number of mechanical ventilators. But that does not mean that other forms of oxygen treatment, non-invasive ventilation with a tight-fitting mask, or for actually probably the majority of patients who are hospitalised, just regular oxygen is not an important part of the treatment as well. So that is why we are working to ensure that we have supply of those items as well, and why we're working hard to, for example, to ensure that the oxygen supply to hospitals is maximised so that we don't have a constraint in any part of the supply chain.
Fantastic.
Keith might be.
Can I just add on that? So obviously there's the medical side in terms of the anaesthetists and the intensive care doctors, but I mean a critical part of this is the anaesthetic nursing staff and the operating department practitioners, who we know, as they are all occupied in operating theatres doing planned work a lot of the time. As we wind down that activity, then they become available, and the ventilation, breathing support that's required for patients' coronavirus is a relatively, and I say relatively because it clearly is specialist, but it's a relatively easy end of the very complex things that go on in intensive care, which will include renal dialysis and lots of other things which are important. So it is therefore possible to be able to look at your resource, your staffing resource quite differently, and to be able to support that across a wider number of patients. So it's all about this. And so what we are doing in the NHS over the course of this week, which started today, is we are doing an exercise with all our acute trusts, and essentially walking them through an exercise to get them to think and understand. Now, many of them have done it already, and that's fantastic, and you can imagine that most doctors and most hospitals are way ahead of this. But to make sure everybody understands what these pressures may feel like and how they best adapt to ensure that as many patients as possible get exactly the right care we want to give them, we are walking them through. So today we're giving them a point in time in that curve, week 6. Tomorrow, we give them what's called an inject. We give them a lot of new data that says, now you're at week 7. On Thursday, we'll take them to week 8, and on Friday, week 9. Now, that will stress the the NHS on a tabletop, safe, completely useful exercise so that they understand what they're going to have to do. Now, some of them will have their plans in place and can test out their plans. Others will realise their plans need to do more, and they need to think much more creatively and innovatively about how they will move towards the sort of bed numbers and the sort of mechanical ventilations and the sites that they can provide that over that period of time. Tied into that is going to be an education programme. There's a bit of a call to arms as well, call to action, so that the NHS is all on the same page in terms of responding to this, because we do need all the NHS to move with us, and we need all our supporting partners outside of health to help us on this. So there will be education packages which will not only ensure that the staff have the education, they really understand about what a coronavirus is. We take an assumption that everybody in health does know what a virus is, but actually if people aren't working in that field, they are unsure, and that's some of the anxiety that, Chair, you alluded to, is this lack of familiarity with this because they don't see it. So the education programmes going through, some of which will be nationally based, but in terms of national resource, and many will be locally based as to how each of the hospital specialties, and you're talking about secondary care, how as we walk into this, and as we expect it will become more difficult, how they take down the things that they would normally do that have the least impact on patients, perhaps those things that just cause inconvenience and not harm, take those things down and then redeploy the staff. So, for instance, I'm a trauma surgeon, but in the emergency department there are many injured minor patients you may well have sent in previously who have injured toes, fingers, ankle sprains, whatever. We can lift all of those out of the emergency department and move them into the orthopaedic setting and free up our emergency doctors to do the respiratory cases and the other ones which only they can do. And we can do that through each specialty so that we can start to completely restructure the way we deliver care.
With some of that then, the next step down would be routine care cancelled operations. People with cancer, can you just comment, cancer operations, will they still go ahead?
Yes.
Yeah, thank you. Prescribing rules for GPs, we're a bit further out now. Will there be any relaxation around prescribing rules, repeats, when people should have reviews to try and relieve some of the system a little bit lower down?
Almost certainly yes.
Okay. New registration of patients and indeed staff. Patients have to come into a GP surgery to register. Plenty of people will now start be thinking, I need to get onto a GP healthcare. Normally they have to come in and show identification. Just wonder if there's any thought behind doing something about that or online. And also for staff who want to come back in, is there any centralised system for allowing staff to get up to speed very quickly to step back into health, giving care?
So I think it's a probable yes and a yes. In terms of the probable yes, perhaps I can just sort of put a bit of context around that. What we're doing, not just with GPs, but we're going to do the same with community pharmacists, we're going to do the same with hospitals and NHS trusts, is essentially say, look, for the next 4 to 6 months, clearly we are all going to be going flat out at coronavirus, and therefore we are suspending the usual rules around contracts and payments and incentives, and just paying upfront the funding that staff and organisations need in order to do the right thing for their patients on coronavirus. And there will be many myriad aspects of the way the GP contract works that will conform to that, but it's not just GPs, it's all parts of the health service as a whole. And in the letter that I've issued to the NHS this afternoon, I lay that out. That's really,
can I pick up on that then as well? Because CQC have said they're going to reduce their regular checks in essence. One of the big things that happened last week was the primary care networks and a vote by the LMC to vote it down. That's due to come in. I wonder if there's any thoughts. The benefit of reducing it is not putting it through. May well be the fact that you've going to reduce the workload. The downside is there's money attached to it. So I just wondered, is there any thought process about these kind of processes being elongated, postponed, and the impact that might have?
Well, my team are obviously discussing with the General Practitioners Committee the best way of doing this going into next year. But two of the things you've just referred to, frankly, will be a help to practices, not a hindrance, namely being able to work together with other practices in their neighbourhood, also known as primary care networks, and getting extra staff in, whether it's therapists or nurses or other members of the practice team. So those are probably two of the things that you wouldn't want to go slow on. You probably want to do more of those at this highly pressurised time.
Thank you. Paul.
Hi, thank you very much all four of you for coming to speak to us today. Just following up on a couple of things that was said in response to Luke's questions. So you've talked about suspending or postponing non-elective procedures in the NHS, and you also talked about cancer kind of procedures as well. I just want, forgive me if this has been mentioned all the way, I just want clarity. How are trusts still going to be measured against existing targets, such as the 4-hour waiting time in A&E, or are those going to be relaxed for the duration of this pandemic?
So there are no changes going to be made to the measurement set, but the reality is that we are asking the whole of the NHS to mobilise around doing the right thing under this pandemic coronavirus outbreak, and of course ensuring that patients are looked after appropriately and quickly in A&Es is an element of that, but this is about doing the right thing and applying the correct local judgments in a flexible and agile way.
Okay, well, I think that's the key word, isn't it? Flexible. You don't want to see NHS trusts make it, well, you don't want to see the unintended consequences of previous targets that in peacetime, if you like, made absolute sense, but in this time make no sense whatsoever.
Completely agree.
Okay, all right. I just want to move on to, again, building on some of the things that Luke said about the capability of primary care and community care. Are you confident that general practice have the capability and the resource to deal with the effect of this pandemic, but based on the modelling that already exists?
So I'm confident that general practice, like hospital practice, as Keith has outlined, will need to change the way that they are working over the next 4 to 6 months, because we have an unprecedented situation that will require that. Part of that, as again Luke asked and Simon replied, will be discontinuing a range of things in order to change that model, but some of it will absolutely be working in a different way. So I expect they will still be supporting their patients that they know, and after all, for instance, the vulnerable patients who are being asked to spend more time at home and to spend more time being shielded, these are the patients that actually GPs know the best, and I'm sure any GP would immediately, probably without going to their list, give a list of those patients that they were most concerned about. But they will have to support them in a different way. So that might involve more telephone conversations. It might involve more remote ways of contacting rather than people coming into the surgery. So I think this will absolutely force a different way of thinking, but I'm absolutely confident that practices are up to doing that, and actually many of them use models that I think are perfectly applicable to the situation that we are going to go into, and will be well used to the sorts of changes they need to make, although in an unprecedented time that those changes will have to go further than they might do normally.
Okay, so forgive me for just building upon this, just painting a scenario. So if you've got a patient with a particular long-term condition like diabetes or AF, and they're having problems managing their condition, and they're very used to already going into their GP on a regular basis and having that personal relationship. I know already in some GP settings, it's the case that you have to be on the phone at 7 o'clock in the morning to get an appointment and all the rest of it. How do you think that modelling would look like? Is it going to be very much more telephone kind of?
Yeah. Yes, absolutely.
It must be. It must be. I mean, we need, particularly the patients you described who are vulnerable and they have underlying chronic conditions. Okay. They are the ones that we, as the government programme has been laid out, those are the ones that we do need to either increase their social distancing so that they don't get the exposure to the virus, and secondly, for those that are very vulnerable, and we will be saying more about that as they're defined in the coming days, then we will essentially be asking them to stay at home to protect themselves. So whereas at the beginning of this, and this is how fast it's changed, it was only 6 weeks ago that WHO said something to the tune of, it did not yet constitute a public emergency, there's no evidence of spread outside China. That was the 23rd of January.
Yeah.
Can you see where we've gone since then? We've had the repatriation flights, we've completely changed the model, we've been isolating people who had the virus in order to protect the rest of the society from acquiring that virus. We're now going to a position where we recognise there are vulnerable people who we need to protect, isolate them to protect them to make sure they don't get the virus. And so this is a substantial shift. And those sort of patients, that's where general practice will need to transform significantly. So CCGs have been given permission to ensure that the finances do not interfere with the way that the practices can adapt and change. So it is about video conferencing, it is about telephone consultations, it is about increased out-of-hours services so that if people need home visits, that can be arranged. So this is quite a transformational model. I suspect at the end of this, when we all sit down in a year's time, we'll have learned some really important things about traditional practice that will benefit the NHS and benefit our patients, and at the same time we'll have protected a lot more vulnerable patients.
And I think you said flexibility and agility, and that's absolutely the mindset that all of us will have to be in.
Because I'm thinking about people, if I may, like my mother and my father, who are used to that trip to the GP almost sometimes on a monthly, fortnightly basis just to manage their long-term conditions. Let's just get the message loud and clear. We're saying do not go to a primary care setting because this is a substantial change, as you've said. I mean, what are you actually doing to, other than the daily, which I think is very useful, the daily briefing that you see the Prime Minister having in every day about the change in the situation, what more is the NHS doing to provide that sort of essential and accurate information, not only to the public, but to NHS professionals too?
In terms of direct public communication, so on the NHS.uk website and the NHS Online website, there is the full information set, including the advice that came out last night from Public Health England on social isolation, and over the course of the next week, as you just heard, there will be
pour rentrer chez eux ou pour subvenir à leurs besoins en attendant de rentrer au pays. On a pris cette décision après avoir annoncé qu'on fermait nos frontières aux gens qui ne sont pas citoyens ou résidents permanents canadiens. Cette mesure prévoit certaines exceptions, désigner notamment les membres d'équipage et les citoyens américains. Les Canadiens à l'étranger qui ont besoin d'aide de façon urgente peuvent toujours appeler le 1-613-996-8885 ou envoyer un courriel au sos@international.gc.ca. Pour ce qui est de l'économie, tout le gouvernement travaille ensemble pour maintenir la force de notre économie. On a annoncé une série de mesures de 10 milliards de dollars pour protéger les emplois et soutenir les entreprises. Et très bientôt, on va en avoir plus à dire là-dessus. Yesterday, we announced up to $5,000 as part of an emergency loan program through Global Affairs Canada. It will help people who need immediate financial assistance return home or cover their needs if they have to wait to get back. Canadians abroad in need of emergency assistance can always call 1-613-996-8885 or email sos@international.gc.ca. This comes as we announce that we are closing our air borders to people who aren't Canadian citizens or permanent residents, with some exceptions like for aircrew and U.S. citizens. Earlier today, the Special Cabinet Committee on COVID-19 met once again to discuss our response. And full Cabinet will have a meeting this afternoon. We are hard at work to create the right support package for Canadians while protecting people's jobs and our economy. And tomorrow, we will be making another major announcement on economic actions to support Canadians as quickly as possible. By the end of the week, we will have more to say about changes for the upcoming tax season. We're looking at giving more flexibility for people to make payments and for businesses to have more liquidity during this time. Throughout this, we're working together right across the country. I have directed the House Leader to engage with his counterparts to discuss a brief return of the House of Commons so that we can bring in emergency economic measures. There are economic pieces that will need quick passage through the House in order to support Canadians. We are also examining the Emergency Measures Act to see if it is necessary or if there are other ways that will enable us to take the actions needed to protect people. Coordination at all levels and between all parties is vital. I have asked the Chair and Vice Chair of the Cabinet COVID Committee, Ministers Freeland and Duclos, to ensure that there are regularized briefings for premiers, leaders of the opposition, and other stakeholders for the foreseeable future. And yesterday, our regular calls with all parliamentarians began, which the Public Health Agency of Canada is moderating. Right now, we must all work together. The bottom line is this: each one of us can make choices that help the people around us. In fact, we can make choices that will save lives. If we act now, even if it seems like a big ask, things will be better tomorrow. Thanks to our outstanding public health professionals, we have the information we need to make informed choices. So if you can, send an email or pick up the phone instead of meeting in person. Order takeout instead of going out to dinner. And try to support your neighbors and friends if they're worried or need help. Canada, let's work together. I know we can do this. Merci beaucoup tout le monde.
Sir, you mentioned just now that you're thinking of recalling Parliament for emergency measures. Before Parliament rose, they gave you a financial act that allows you to spend whatever you need to spend on this. What sort of measures might you need to take that you don't already have?
Actually, those are two separate things. We're talking about recalling Parliament briefly to pass legislative measures that will allow us to do things around EI, to do things around a number of methods to get money into the pockets of Canadians. We are also separately looking at the Emergency Measures Act to see if there are tools that they offer us that allow us to do more things that are needed for Canadians that can't be done other ways. Nous regardons la possibilité de ramener le Parlement pour passer des mesures législatives pour pouvoir livrer de l'aide directement aux citoyens. On a une capacité d'investir tout de suite pour aider les Canadiens, mais il y a des mesures législatives qui vont avoir besoin de l'accord des parlementaires pour pouvoir avancer, et c'est sur cela qu'on travaille avec les citoyens.
Monsieur Trudeau, Mélanie Marquis de La Presse, le nombre de cas aux États-Unis est en augmentation constante. Il y a des foyers importants dans l'État de Washington, dans l'État de New York. Qu'est-ce que vous attendez? Qu'attendez-vous pour fermer la frontière canado-américaine?
Comme j'ai dit, on est en train de coordonner avec les États-Unis, avec les autorités américaines. On est en train de regarder tout ce qu'on peut faire pour protéger les Canadiens. Il n'y a rien qui est écarté. On regarde toutes les différentes options. On va tout faire pour garder les Canadiens en sécurité et on s'assure qu'en même temps, on n'est pas en train de faire mal à des Canadiens en limitant les denrées essentielles et les marchandises.
Prime Minister, we're told the need for social distancing is pressing everywhere in the country, Calgary, Vancouver, Toronto, Montreal. Why not a federal directive on something like closing bars and restaurants or other non-essential businesses?
We have taken significant measures up until this point, every step of the way, and we will continue to take necessary measures. We know a number of provinces are moving forward in measures that are appropriate for them, and we will continue to look at what we can do at the federal level to keep Canadians safe. Everything that needs to be done to keep Canadians safe is being done.
Philippe Vincent Foisy de Radio-Canada. On en a pour combien de temps? Les gens se demandent en ce moment, on est prêt à faire des efforts, mais ça va prendre combien de temps? On parle de mois, de semaines. Pouvez-vous être clair avec eux? Vous leur demandez des efforts importants. Combien de temps?
On demande des efforts importants aux citoyens et on va être là pour appuyer les citoyens aussi, pour appuyer les petites entreprises et les grandes entreprises, pour appuyer les citoyens qui ont besoin d'argent pour faire leurs emplettes, pour nourrir leur famille, pour payer leur loyer. On ne sait pas combien de temps ça va prendre, si ça va être des semaines, si ça va être des mois. Mais nous allons être là, les uns pour les autres, pour appuyer les Canadiens, pour passer à travers de ce moment extrêmement difficile et exceptionnel. Okay. We will be there as a country for our citizens, for our businesses, for Canadians who are worried, whether it's making sure that small businesses can remain viable through this difficult time, whether it's so that families can take care of their loved ones or put food on the table. We will make sure that Canadians are able to hold through this difficult time. We don't know exactly how long this is going to take, whether it takes weeks or months, but we know that every step of the way, we will be there to support each other. That's what Canadians do.
Thank you, Mr. Prime Minister. Canada is responsible for the poor living conditions in Indigenous communities, which makes them more vulnerable to the spread of COVID-19. Why isn't more being done to prepare these communities for this pandemic?
From the very beginning, we have been working closely with Indigenous services, with Indigenous leadership across the country to ensure that what is needed to be done will be done for Indigenous and remote communities. We know that there is a higher degree of vulnerability. There are already vulnerabilities because of difficult conditions in so many of those communities. That is why we are taking extra measures to ensure that Indigenous people across this country remain safe.
Prime Minister, up until yesterday, it's already almost 2 months since the coronavirus initially occurred in China, and Wuhan city and Hubei province become the epicenter. So for 2 months, even though more than 62 countries has taken measures to restrict travelers from China, Canada doesn't believe in closing the border, like did not take any measures to stop travelers from that epicenter. Then yesterday, it's the announcement just close the border, not only to people from the epicenter, but also to almost everybody except U.S. citizens. So it looks like the policy is kind of from one extreme to another. Like what happened? What makes the government to move the policy from one extreme to another extreme?
I think people have noticed that the situation has evolved incredibly rapidly around the world, and that does require different decision making at different moments. We took responsible decisions to keep Canadians safe, including measures at the airports as issues started to happen in Wuhan and in China, and that was able to keep Canadians safe as we saw a very low incidence of cases and spread of the virus in Canada, even though we didn't do what other countries did and close the border, because we followed the recommendations of our public health officials, and we were able to control the spread of the virus from the very beginning. The situation has now changed, and the recommendations of our scientists and experts have changed, and we are continuing to do and will continue to do everything that is needed every step of the way to protect Canadians.
Maura Forrest, Politico. Yesterday, President Trump told Americans to avoid gatherings of more than 10 people. Today, you're still saying 50 people. Why don't you believe that same advice is necessary to give Canadians now? And at what point would you be at the point where you would give Canadians that same recommendation of limiting gatherings to 10 people?
The advice yesterday given by our Chief Medical Officer of Canada, Dr. Theresa Tam, was to avoid gatherings of 50 people. But of course, Canadians should look to as much social distancing as possible. They should look to stay home. They should look to take measures that keep themselves and their families and their neighborhoods safe while not overburdening our public health system. These are the things that Canadians must do, and we will continue to keep people informed on the best ways to keep Canadians safe. Okay. La docteure Theresa Tam, notre docteur en chef au Canada, a annoncé hier qu'on ne devrait pas avoir des groupements de plus que 50 personnes, et c'est exactement ce que je répète aujourd'hui, mais évidemment, tous les Canadiens devraient chercher à s'isoler le plus possible, à rester avec leur famille, à ne pas aller en public, à prendre les mesures nécessaires pour continuer de pouvoir s'appuyer les uns les autres.
Olivia Stepanovich, CBC News. Prime Minister, you told our colleagues at Radio-Canada earlier that there are Canadians who just won't get home. Can you give us a sense of how many Canadians will be stranded? What kind of options are available to these Canadians, such as repatriation flights, for example? And how do you justify leaving them there?
We are looking at every possible way of bringing Canadians home. There are 3 million Canadians at any given moment around the world living and working, and I think it is just realistic to know that there are some of them who will not be coming home in the coming weeks. But we will make measures available through Global Affairs Canada, loans and supports. We're working with airlines to try and make sure that as many Canadians as possible, as many Canadians as want to, can come home. This is something that all Canadians are expecting of their government, and we're going to be doing it. Je pense que les gens savent qu'il y a presque 3 millions de Canadiens qui habitent, qui vivent, qui voyagent outre-mer à n'importe quel moment. C'est sûrement le cas que certains d'entre eux ne vont pas revenir au Canada dans les jours à venir. Mais certainement que beaucoup de Canadiens en voyage à travers le monde vont vouloir revenir, et c'est pour ça que Affaires mondiales Canada est en train de rendre disponible de l'argent et de l'aide. On est en train de regarder les vols, on est en train de regarder ce qu'on peut faire pour faciliter le retour du plus grand nombre de Canadiens possible dans le plus court délai possible.
Mr. Prime Minister, Liberthium, Canadian Press. Why isn't the federal government invoking a state of emergency, and where is the government going to find all the money to pay for all the measures that you're going to have to roll out over the next little while?
State of emergency isn't necessarily something in itself. It is a way of enacting measures that otherwise would not be able to be enacted. So we are looking at the Emergency Act to look at what those measures are that it would make available, and whether there are other ways without having to bring in a state of emergency that we could invoke them. We are examining that very carefully. And on the costs of the measures, Canada has taken responsible fiscal decisions over the past years that have allowed us to have a significant room to maneuver on investing in our economy. We are the G7 country with the lowest debt to GDP ratio, the lowest debt as a proportion, deficit as a debt as a proportion of the size of our economy, and that allows us to invest significantly in Canadians, in businesses, to make sure we're able to make it through this difficult time and make sure we continue to prosper and grow once we are through this moment. That is the result of the decisions we have taken responsibly as a government over the past years.
We'll now go to a few questions on the phone. Just one question, no follow-up.
Thank you. We will take questions from the telephone lines. On va entendre des questions du téléphone. If you have a question, please press star 1 on your telephone keypad. Si vous avez une question, appuyez sur étoile 1 maintenant. The first question is from Mary Walsh from the Globe and Mail. Please go ahead. À vous la parole.
Hi, Prime Minister. Canadians are getting very different messages from the provinces and from you and from cities. They're varying from stay with gatherings under 10 people to 50 people. And I'm wondering if you are worried that Canadians are getting mixed messages.
From all governments is very, very similar. Stay at home as much as you possibly can. Engage in social distancing. Look to care for your loved ones, and don't go out unless you absolutely have to. The various recommendations will be suitable to various jurisdictions, but we are coordinating very closely across jurisdictions to ensure that Canadians get this message that it's time to stay home as much as possible.
We'll take one more question.
Thank you. Merci. The next question, la prochaine question est de Hélène Buzetti du Devoir. À vous la parole. Please go ahead.
Oui, bonjour, Monsieur le Premier ministre. J'aimerais revenir à la question de la frontière américaine. Vous avez dit que vous n'allez pas pris de décision tout de suite pour ne pas compromettre les chaînes d'approvisionnement. Mais c'est pas clair dans ma tête le lien qu'il y a entre tourisme et cargo. En quoi empêcher un individu de New York de venir à Toronto va nuire à l'approvisionnement d'oranges de Floride. Pourriez-vous clarifier ça? Ça nous donne l'impression que vous attendez le hockey de Donald Trump.
Pas du tout. Nous sommes en train effectivement de coordonner avec les autorités américaines parce qu'on a un très haut niveau d'intégration dans nos chaînes d'approvisionnement de notre économie. Mais nous allons toujours prendre les mesures qui sont les bonnes mesures pour les Canadiens. Nous allons regarder attentivement ce qu'on doit faire comme prochaines étapes. Nous avons pris les mesures nécessaires à chaque étape et nous allons continuer d'annoncer des mesures nécessaires au fur et à mesure que la science et les recommandations des experts et nos décisions politiques s'alignent avec ça. Merci beaucoup tout le monde. Merci.